Hello and welcome to this episode of Cardioid. In this episode of Cardioid podcast, we'll be talking about revascularization in stable ischemic heart disease and 2021 ACC, AHA and SCAI Coronary Revascularization Guidelines. If you are coming to our channel for the first time, we regularly discuss recent advances and basic concepts in the field of interventional cardiology, general cardiology, cardiovascular imaging. So you can consider subscribing the channel. Now coming to revascularization in stable CAD, as per the 2021 ACC AHA SCAI guidelines, what they have said is that in patients with stable ischemic heart disease and multivessel coronary artery disease appropriate for CABG with severe left ventricular systolic dysfunction, that is ejection fraction less than 35%, coronary artery bypass grafting is recommended to improve survival. And this is class 1 recommendation. In selected patients with stable ischemic heart disease and multivessel CAD appropriate for CABG with mild to moderate LV dysfunction, that is ejection fraction of 35 to 50%, CABG is reasonable to improve survival, and this is class 2A recommendation. So we already know that CABG is better than medical therapy, especially in 3 subsets of patients, that is multivessel disease, ischemic cardiomyopathy and left main CAD. No randomized controlled trial has demonstrated the advantage of PCI over medical therapy in patients with stable ischemic heart disease. PCI may have some advantage over the medical therapy in patients who have an indication for CABG, but they are at prohibitive surgical risk. The ischemia trial had randomized patients with stable ischemic heart disease and moderate to severe ischemia on stress testing to an initial conservative or initial invasive strategy. Patients with left main disease or ejection fraction of less than 35% were excluded from this study. This study found that an invasive strategy was not associated with improved outcomes as compared to medical management. And invasive strategy here meant both PCI and CABG. The findings of ischemia trial do not apply to the patients who have an ejection fraction of less than 35% or who have significant left main coronary artery disease. The current guidelines have recommended that if ejection fraction is less than 35% and patient has a multivessel coronary artery disease, coronary artery bypass grafting is recommended. This is class 1 recommendation. The strongest evidence that has supported the role of coronary artery bypass grafting in patients with LV dysfunction has come from STITCH trial. The STITCH trial included the patients who had ejection fraction of less than 35% and randomized them to 2 groups. One was CABG with medical therapy and other was medical therapy alone. This study found that at 5 years there was no significant survival benefit for CABG, whereas at 10 years there was a significant survival benefit with CABG compared to medical therapy alone. The 2 studies, CAS study, that is coronary artery surgery study, and Veterans Administration coronary artery bypass cooperative study with LV dysfunction, have shown the benefits of CABG in patients with stable ischemic heart disease and moderate LV dysfunction. That is why the guidelines currently recommend that in patients with stable ischemic heart disease and multivessel CAD appropriate for CABG who have an ejection fraction of 35 to 50%, CABG is reasonable to improve survival, and this is class 2A recommendation in the current guidelines. Now talking about the left main coronary artery disease. In the guidelines, it is recommended that in patients with stable ischemic heart disease and significant left main stenosis, CABG is recommended to improve survival. This is class 1 recommendation. In selected patients with stable ischemic heart disease and significant left main stenosis for whom PCI can provide equivalent revascularization to that possible with CABG, PCI is reasonable to improve survival, and this is class 2A recommendation. In the Veterans Administration coronary artery bypass surgery cooperative study, 15% of the patients enrolled had significant left main disease. At 42 months of follow-up, CABG was associated with survival advantage in patients with left main disease. Besides this, a meta-analysis of randomized controlled trials which compared CABG with medical therapy supported the role of coronary artery bypass grafting in patients with left main disease. What we very clearly understand that in patients with left main coronary artery disease, CABG is superior to medical therapy and it is class 1 recommendation. Now coming to the role of PCI in patients with left main CAD. The randomized controlled trials and meta-analysis of these trials have shown that in patients with low to medium anatomic complexity of coronary artery disease and left main disease that is equally suitable for CABG and PCI, survival is similar with both PCI and CABG. So, the current guidelines recommend that PCI is reasonable to improve survival in patients with stable ischemic heart disease and significant left main stenosis. And this is class 2A recommendation in the current guidelines. Now coming to multivessel CAD. In the current guidelines, it is recommended that in patients with stable ischemic heart disease, normal ejection fraction, significant stenosis in 3 major coronary arteries, and anatomy suitable for CABG, CABG may be reasonable to improve survival, and this has been downgraded to class 2B recommendation. We now understand that there is no advantage of CABG or medical therapy in improving survival in patients with 3 vessel disease and preserved ejection fraction and no left main disease. Ischemia trial has already shown us that even if the patient has moderate to severe ischemia with stable ischemic heart disease, an initial invasive strategy comprising of either PCI or CABG does not carry any advantage over the initial conservative strategy. So this is something which is controversial in these guidelines, and it is still included in the guidelines. It has been given class 2B recommendation. The writing committee of these guidelines has recommended that CABG may be reasonable as a revascularization strategy to improve survival in patients with stable disease versus medical therapy alone. What these guidelines also recommend is that in patients with stable ischemic heart disease and normal ejection fraction, significant stenosis in 3 major coronary arteries with or without proximal LAD and anatomy suitable for PCI, the usefulness of PCI to improve survival is uncertain, and this is class 2B recommendation. Now, what if the patient has stenosis in proximal LAD? So, the current guidelines recommend that in patients with stable ischemic heart disease and normal ejection fraction, significant stenosis in proximal LAD, the usefulness of coronary revascularization to improve survival is uncertain. This is class 2B recommendation. Previously, it was believed that CABG is better than medical therapy for patients with proximal LAD stenosis. Then a meta-analysis also found that PCI is better than medical therapy for patients with disease in proximal LAD. In the year 1995, a study known as the MASE study, that is medicine, angioplasty or surgery study, found that there was no difference in the event rates with either CABG or PCI or medical therapy when patients had multivessel CAD involving proximal LAD. In the ischemia trial, approximately 50% patients had more than 50% stenosis in the proximal LAD. So what we understand now that even if disease is present in proximal LAD, the usefulness of coronary revascularization to improve survival is uncertain. A general principle is that the more myocardium is at risk, the greater is survival advantage of revascularization over medical therapy. And in patients with little myocardium at risk, that is 1 or 2 vessel disease without LAD involvement, there is likely no survival benefits of revascularization in patients with stable ischemic heart disease. So the current guidelines do not recommend coronary revascularization to improve survival in patients with stable ischemic heart disease, normal ejection fraction, and 1 or 2 vessel CAD not involving proximal LAD. This is class 3 recommendation. Besides this, what these guidelines say that in patients with stable ischemic heart disease who have more than equal to 1 coronary arteries that are not anatomically or functionally significant. What is anatomically significant stenosis? It is more than 70% non-left main artery stenosis. And what is functionally significant disease? FFR of less than 0.8. So the guidelines say that in patients with stable ischemic heart disease who have more than equal to 1 coronary arteries that are not anatomically or functionally significant, coronary revascularization should not be performed with the primary intent to improve survival. The bypass of a non-obstructive disease can stimulate the progression of CAD, and PCI of a non-obstructive disease can produce periprocedural MI. So we do not want these things to happen, and it has been found that all these procedures do not improve outcomes. So this is also class 3 recommendation. Revascularization to reduce cardiovascular events in stable ischemic heart disease compared with medical therapy. In patients with stable ischemic heart disease and multivessel CAD, appropriate for either CABG or PCI, revascularization is reasonable to lower the risk of cardiovascular events such as spontaneous MI or unplanned urgent revascularization or cardiac death. The MASS II study had found that 10 years risk of cardiovascular death was lower after coronary artery bypass grafting or PCI than after medical therapy. A meta-analysis also found lower rates of cardiovascular death after revascularization than with medical therapy. However, other studies have found no difference in cardiac death after revascularization than with medical therapy alone. Cardiac death may be related to occurrence of MI. MI can occur after revascularization also. The incidence of type 4A or type 5 MI is higher after revascularization, but the incidence of late spontaneous MI or type 1 MI is reduced with revascularization. Ischemia trial has found that all-cause death is increased in patients with spontaneous MI but not with procedural MI. Spontaneous MI can be reduced by revascularization compared to medical therapy alone. So, in patients with stable ischemic heart disease and multivessel CAD, revascularization is reasonable to lower the risk of cardiovascular events such as spontaneous MI or urgent revascularization or cardiac death. And this is class 2A recommendation in these guidelines. Revascularization to improve symptoms. In patients with refractory angina despite medical therapy with significant coronary artery stenosis amenable to revascularization, revascularization is recommended to improve symptoms, and this is class 1 recommendation. In patients with angina but with no anatomic or physiologic criteria for revascularization, neither CABG nor PCI should be performed. This is class 3 recommendation. In patients with stable ischemic heart disease, medical therapy is an effective option. Studies have shown that revascularization can result in greater improvement in angina or quality of life than medical therapy alone. Some patients who are intolerant or unwilling to take anti-anginals may be benefited from revascularization. The ORBITA trial, which randomized the patients to a PCI or sham procedure, did not support the improvement of symptoms with PCI and raised the questions about the placebo effect of PCI. However, the ischemia trial reported a clinically relevant improvement in symptoms at 3 years after PCI or CABG. Benefits in symptoms at 3 years is important. This is a long time after which placebo effect should have dissipated. This difference was most pronounced among the patients who had more frequent angina at baseline. Situations in which PCI or CABG would be preferred. Number 1. Patients with complex disease. In patients who require revascularization for significant left main CAD and highly complex CAD, it is recommended to choose CABG over PCI to improve survival. And this is class 1 recommendation. In patients who require revascularization for multivessel CAD with complex or diffuse CAD, that is SYNTAX score of more than 33, it is reasonable to choose CABG over PCI to confer a survival advantage, and this is class 2A recommendation. The SYNTAX trial included 700 patients with left main disease and a range of complexity of disease and showed significantly higher MACE and cardiac mortality at 5 years for patients with left main disease and high complexity disease. The factors which can contribute to anatomic complexity include severe tortuosity, heavy calcifications, complex bifurcation or trifurcation lesions, arteriosteal lesions, thrombotic lesions. The SYNTAX trial reported similar mortality rates with CABG and PCI in overall group of patients. Extended follow-up found that there was a 40% higher mortality with PCI in group of patients with triple vessel disease. Many studies found that extent and diffuseness of coronary artery disease on angiography predicted the survival advantage of CABG over PCI. The all-cause mortality observed after CABG was lower than that observed with PCI in patients with diffuse CAD that is, a SYNTAX score of more than or equal to 33. In patients with SYNTAX score less than 33, there was no difference in mortality rate. What we infer from the results of this trial is, for patients who have high complexity CAD, it is better to choose CABG over PCI to improve survival. For patients with low complexity disease, PCI can be used. What we also need to remember is that SYNTAX trial included the patients who were treated with first generation drug-eluting stents. Number 2, revascularization in patients with diabetes. So diabetes is associated with 2 to 4-fold increase in mortality from heart disease. And patients with diabetes have more aggressive atherosclerosis, they have more diffuse lesions and smaller coronary arteries. After revascularization, patients with diabetes experience higher mortality and have greater need for repeat revascularization. Trials have shown that in patients with diabetes and multivessel disease, PCI is associated with higher mortality at 5 years than CABG. The recommendations of ACC, AHA and SCAI in patients with diabetes are: Number 1. In patients with diabetes and multivessel disease with involvement of the LAD who are appropriate candidates for CABG, CABG with Lima to LAD graft is recommended in preference to PCI to reduce mortality and repeat revascularization, and this is class 1 recommendation. In patients with diabetes who have multivessel disease amenable to PCI and an indication for revascularization and are poor candidates for CABG, PCI can be useful to decrease long-term ischemic outcomes, and this is class 2A recommendation. In patients with diabetes who have left main disease and low to intermediate complexity of CAD in the rest of the coronary system, PCI may be an alternative to CABG to reduce major adverse cardiovascular outcomes, and this is class 2B recommendation. The FREEDOM trial is the largest study which has compared PCI with CABG in patients with diabetes. FREEDOM trial included 1900 patients with multivessel disease and stenosis of more than 70% in at least 2 major epicardial coronary arteries. The 5-year follow-up data of this trial showed that all-cause mortality was higher in the patients who were treated with PCI than those treated with CABG. However, the cardiovascular mortality rate was not statistically different between the two groups. In the FREEDOM trial follow-up data, the all-cause mortality rate up to 8 years was significantly higher with PCI. However, patients who are diabetic and are at high surgical risk and require coronary revascularization are more likely to be treated with PCI in our practice. Observational data has shown that high-risk patients with refractory ischemia have similar 5-year survival rates with either CABG or PCI. No randomized controlled trials have compared CABG and PCI in patients with diabetes and left main disease. In the EXCEL trial, which included patients with left main disease and low to intermediate complexity CAD, approximately 30% of the patients had diabetes. The trial found that at 3 years, the composite of death, stroke or MI was not significantly different between PCI and CABG among patients with diabetes. However, the all-cause mortality rate was almost 2 times higher in PCI group. That is why the current recommendations are diabetes with multivessel disease with an LAD involvement, CABG is recommended in preference to PCI. Diabetes with multivessel disease, patient is a candidate for revascularization, and poor surgical candidates, PCI becomes class 2A. Patients who have left main disease and diabetes and have intermediate to low complexity CAD, PCI is class 2B to reduce major adverse cardiovascular events. Number 3. Patients with previous CABG. In patients with previous CABG and patent Lima to LAD graft who need repeat revascularization, if PCI is feasible, it is reasonable to choose PCI over CABG. This is class 2A recommendation. In patients with previous CABG and refractory angina on medical therapy that is attributable to LAD disease, it is reasonable to choose CABG over PCI when Lima can be used as conduit to the LAD, and this is class 2A recommendation. In patients with previous CABG and complex CAD, it is reasonable to choose CABG over PCI when an internal memory artery graft can be used as a conduit to LAD, and this is class 2B recommendation. In patients who have previous CABG, PCI of native vessel or saphenous vein graft is indicated in preference to redo CABG, especially if lima to LAD is not planned or patient already has a patent lima to LAD graft. Studies have shown that PCI has lower in-hospital stroke and mortality rate as compared to repeat CABG, although long-term mortality rate is similar. In patients who have acute graft closure, PCI of native vessel is performed in preference to redo CABG or treating acutely thrombosed graft with fresh suture lines. Patients who already have a previous CABG are at increased risk during repeat CABG. There are high chances of in-hospital death and stroke as compared to PCI. If PCI is not an option and internal memory artery to LAD graft is not present, or internal memory artery is available to be used as a conduit to LAD, a redo CABG can be used in patients who have previous CABG and refractory angina, provided the patients are at acceptable risk of reoperation. Number 4, dual antiplatelet therapy adherence. In patients with multivessel disease amenable to treatment with either PCI or CABG who are either unable to access or not able to tolerate or not going to adhere to dual antiplatelet therapy for appropriate duration of treatment, CABG is reasonable in preference to PCI. So, premature cessation of dual antiplatelet therapy after PCI is associated with stent thrombosis and poor outcomes including death. Therefore, in these patients, PCI becomes a poor method of revascularization. Stent thrombosis after PCI is associated with large territory MI and poor outcomes, and death rates may be as high as 50% for patients with early thrombosis. If dual antiplatelet therapy is interrupted for any reason, it can be bleeding, it can be procedure, or it can be non-adherence, it is a reversible risk factor which is strongly associated with stent thrombosis. So CABG is a safe revascularization option in patients who are not likely to be adherent to dual antiplatelet therapy. You were listening to CardioEd, and we'll meet again in another episode discussing more about 2021 guidelines of myocardial revascularization that have been given by ACC, AHA and SCAI. Thank you.